Let's welcome back Ursula from Birth You Desire. Ursula, thank you so much for coming on the show today. How you doing?
I'm doing great. How are you, ladies?
Doing well. Excited to get into it about C-section today.
Yes.
So, Ursula, even though you've been on the show recently, give us a little bit of backstory. And if you're okay with it, share a bit about your story and
Ooh.
your birth.
So I own and operate a company called Birth You Desire. It's an award-winning doula and childbirth practice. We have a concierge team that is focused in the DC metropolitan area, and we have a team here in the Phoenix metropolitan area. We do everything from fertility through the first year postpartum. So soup to nuts, anything you need, we can help you out, from consulting to classes to doula services, products, services, all of that. Um, I My personal birth story is a very interesting one, and we probably don't have time for the whole story, but I'll give you the synopsis. I was told I probably wasn't going to be able to have kids. And then I wound up being diagnosed with endometriosis, and then I wound up being diagnosed with cervical cancer. And through the treatment of that, when we were all done with 2 years of treatment, which was a negotiation between the doctor and I, between what was recommended at the time, which is not what is being currently recommended as treatment. Anyway, so he told me I had a very tight window to have kids. I came home and I told my husband we're having babies, and he said, "Excuse me?" And I said, "Change of plans. I can have kids. We have a very short window. Like, let's do this." And he said, "Okay." And I wound up having two children in a birth center with midwives. Even though it was a high risk pregnancy, I had an OB on standby, but the midwives were able to manage me in the birth center in New Jersey. The birth center's now closed, but it was attached to a hospital. So if care changed, you could just move down the hallway. And I wound up having two great, wonderful, amazing births that changed the way I saw my body, people's bodies, birth, what was possible when you set your mind to it and when you did your prep work. And then that led me into taking a refresher class with my second. And I met a really good friend named Sheila. And Sheila invited me to her birth for childcare for her son, Connor. She and I used to trade off babysitting for each other's kids. And during her labor, it was expedited. And I wound up walking into the hospital with her while her husband was parking the car with their son. And she got onto the toilet and she started pushing on the toilet right around the time her husband and son walked in the room. And I said, "Okay, let's switch spots." And he goes, "Oh, no, yeah, you're doing that really good. Connor really wants me. I'll stay over here with Connor." And very suddenly, Sheila started pushing, and I was yelling out in the hallway, "Hey, we're pushing in here. We need a nurse. Hey, we're crowding in here. Is anybody coming in?" And I was literally in the process of delivering the baby, squatting over the toilet as the midwife walked in. And I had the head and the shoulders, and she got the baby's feet, and we finished the delivery. And that's how my adrenaline junkie birth story started.
Wow.
Yeah.
So did you yourself have both deliveries, were they vaginal or did you have a C-section?
I did not. I had two vaginal deliveries. My deliveries were on the shorter side, which always makes people very jealous. But when you have a short delivery, it's kind of like a roller coaster ride, the scream machine. You're holding on, going up, and then all of a sudden you're just sort of screaming as you're going down because everything is just happening so quickly. So I had fast deliveries. There were vaginal deliveries. Interestingly enough, when you pull people after they've had deliveries, if you ask them, like, what's the ideal timeline? Most people say somewhere between 8 to 12 or 15 hours is the ideal time that somebody would like to be in labor. And they say that because it's enough time for them to orient themselves to being into labor
Mhm.
and be in labor before they welcome their baby. It's enough time for them to physically, mentally, and emotionally process what's happening.
That makes sense. I could see how, you're in this thing that you've never experienced before, and it being like a really like just quick thing, that could be hard emotionally. So that's interesting. Is that too like, is that what you hear from most women, or is that also just like based on studies of what women have said as well? Um,
So the studies show that for sure. I would say most of my clients probably say closer to the 12 to 24, and that includes that early like pot brewing. Oh, is this labor? Is this not labor?
mhm.
I think 8 hours of actual like regular contractions before you meet your baby for most people is really a sweet spot.
It, at what point then at what point is it decided that a C-section is necessary?
Sure. So if somebody is in labor, things that would cause the providers to say you need a C-section is non-reassuring heart tones. And that's something we spoke about the last time we spoke
Mhm.
together, where the baby's heart rate is not doing what the team thinks is within the bounds of safety. Another reason would be if we're in labor and baby's not descending, or if we've been pushing for a long time and baby's not descending.
Mhm.
If mom or the laboring person develops health concerns in labor, it could be that they had preeclampsia that has now become something called HELP syndrome,
Mhm.
or the baby's wedged in such a way, or that mom's health, the laboring person's health has deteriorated. Maybe their kidney functions, maybe their blood pressures are too high, maybe there's things with the laboring person that we need to manage, and the safest thing would be delivery. That would be another reason. Those are the most common reasons why somebody would deliver in labor, like non-reassuring heart tones, a labor that's not progressing, a baby that doesn't fit, or a pelvis that doesn't accommodate, and then maternal or infant health.
With timeline in labor, is there a specific timeline that the birth team considers? Let's say mom's health is fine, baby's health is fine, but it's now they're in labor for 36 to 48 hours.
Yeah.
At that point, what's the conversation across the medical team?
It depends. So the first thing that we kind of need to assess is that different providers in different facilities have different timelines. So it's really critical to know about your provider and their expectations and yours. Another piece of that is your personal expectations. So if Jordan's in labor and she's 36 hours in and she goes, I'm cool, let's keep going, then we keep going as long as there's no medical necessity, right? The American Congress of Obstetricians and Gynecologists, ACOG, says that we should not call a C-section until you've been stuck at 6 centimeters for a minimum of 8 hours. Now, that doesn't always hold true, right? It is America. We do get to make choices. So, Jordan, we're just going to use you as our example for
Mhm.
today. I used Jocelyn last time. Jordan's in labor, and at some point she goes, look, this is too physically exhausting, this is too mentally exhausting. I have trauma that's showing up, I'm concerned about trauma. My grandmother died at midnight, yes, tomorrow, I don't want to have my baby on that day, or for whatever other reason that is important to her. It is her legal right to be able to say, I want to change plans here. But there is also a conversation there to be had with the provider, where the provider comes in and says, I understand what your concerns are, but continuing is the best bet for you and your
Mhm.
baby. Or, we don't have room to take you back right now. Even if we were to take you back, we're not going to have your baby delivered until tomorrow. It's a dance. It's a dance for sure.
Throughout the conversation, that you're having with, the person in labor, how
Yeah.
often are you having them change positions or, things like that to potentially help assist them? And are you really only making those recommendations if they kind of have been practicing and preparing, or is it sometimes just like, I think you should try this?
So it's both.
Okay.
So ideally, through the prenatal, through their childbirth class, they learn the importance of movement and changing positions. As a doula, most of us are taught that when the individual is sleeping, that we can let them sleep for 45 minutes, an hour at a time, and then we should wake them up and change their position. If we know the baby's large or malpositioned, or depending on what the individuals, if they're medicated or not medicated, ideally we're changing positions closer to every 15 or 30, because a moving maternal body, a moving pregnant body helps the baby to move. It's like a key in a lock. We can stick the key in the lock, the key is the baby, but not all locks unlock. Sometimes we have to jiggle the lock, sometimes we have to pick up the door. So in order to wiggle the lock, we have to wiggle the laboring person until
Okay.
the key and the lock can fit together, right? So changing positions is ideal, and that's why delaying the medications or the epidural until someone's in more active labor or in transition or not at all is considered ideal, because that allows us to get feedback from the person who's laboring, who says, this is what I'm feeling, this is where I'm feeling it, these positions feel better to me. And then we can work with their body, not just the baby's position. The dance changes when you're medicated, but we still move. We still move. And the movement is actually oftentimes more critical, because the laboring person is not aware of what's going on in their body. They're not aware of time change. So having a doula there, or a really amazing nurse who doesn't have any other patients that day, so she can give you all that attention and do all those position changes with you is really, really important. There's plenty of medical studies to document that.
And to those of you that are listening, if you want more information about movement and just the laboring process and working with a doula, check out our episode that we recently published prior to this one on that topic. So let's say mom or the in labor, things are just not progressing, or something is happening. The decision is to move towards a C-section. Now what? What decisions have to be made?
Great question.
Like emergency versus, the timeline there. And then like, are there different types? Does the person who is pregnant, do they have the opportunity to choose? Like what's next?
Okay, fantastic. So, and I wasn't even thinking about this when I was preparing for this call. So great question. So from the time your provider comes in and they say, we're concerned about what's going on, X, Y, and Z reasons, you've been doing this for X, Y, and Z, we think we need to go back for a C-section, there's a conversation that is had where the family gets to ask questions like, what's going on? Why are you saying that? What is that going to look like? And again, ACOG says that there is usually a 20-minute window between the provider coming in the room and you going back for the C-section. That is the recommended timeline. I will say to you, at least 80% of the time we go past that. So usually when a provider comes in and says, we need a C-section, or we should be thinking about a C-section, there's lead up to that and there's some time. Now, at that point in time, there's more paperwork to be signed. So the provider sits down, they tell you what's going to be going on, and you sign a C-section consent. Okay. Now, if the situation is that the baby is crashing, or the laboring person is crashing, the provider is going to run in with a whole bunch of other people. You're going to know it's an emergency, and the consent that you signed upon admission actually covers them for an emergency cesarean. And so we should talk about that in just a second. But so we have two scenarios. You're laboring, labor's not going well for whatever reason. We need to go back for a C-section. We have time to talk about it. We have time to make requests. If pain management's not on board, we can discuss what type of pain management, because we have 2 or 3 options there. And the second scenario is they come in and we're doing what we call a crash or a stat C-section, which is the true emergency C-sections, which only are 1% of all C-sections that are done. So if our C-section rate is 1/3 in the United States, only 1% of that 1/3 is a true emergency.
Okay.
Okay. Those individuals do not have a choice on anesthesia if they are not medicated, or if we don't have enough time to increase their medication. We do have to use general anesthesia because we are in an emergency situation. and the providers are not, the partners are typically not allowed in. And we literally run them down the hallway. We put them under general, and their babies are typically born in less than 5 minutes. So 2 very different scenarios.
And then what happens when it's not an emergency?
So if it's not an emergency and you're not medicated, you get to walk down the hallway. You get to hop onto the OR table, receive your anesthesia, lay there, let the anesthesia take effect, which is about 20 minutes for most people. And then the process is to drape you, to wash your belly with a betadine solution. They test to make sure that you're numb. They get you ready to go. They have a catheter in place for your bladder. Then they walk your partner in. They sit behind the screen at your head. So normally the laboring person's laying on the cot with their arms out. One has an IV in it, one has a blood pressure cuff in it. We do not tie people down anymore. Rather, anesthesia gently holds, or rests their hand on one side, and we encourage the partner to rest their hand on the other side. Anesthesia is usually at your right side, and your partner is usually at your left side. And there's a huge blue screen in front of you, so you see the drape, you don't see the procedure. At that point, the procedure is started. It's typically 5-10 minutes to the baby, just because they have to cut through the skin, separate the muscle manually, break the bag of waters, reach in for the baby, and deliver the baby. And when it's not an emergency situation, we can take our time with that, right?
Mm-hmm.
Then in most cases, they lift up the baby and they sort of go Simba the baby over the screen, and they go, here's your baby. And then they pass the baby to the NICU team to check the baby out. Some hospitals do what is called a family-centered cesarean, which means there's that blue drape, and on the other side of the blue drape is a clear drape. And if the family would like, they can drop the blue drape as the doctor's lifting the baby out, so that the laboring person can kind of like prop up their head and they can just see their baby emerging. So they get that emerging piece. Sometimes the partners can see a tiny bit more. And then once the baby's out, they put the screen back up. There's a couple of providers overseas that actually put long sterile gloves on the moms, and they can actually, or the laboring person, and they can reach down and lift the baby out themselves with the doctor's help. We're not doing that a whole lot here in the US.
Mm.
And then just to complete, it takes almost 30 minutes to 45 minutes to close you up and to put everything back where it goes. So the baby comes out quickly, but everything else takes time after that.
And for like, so with the emergency cesareans, there's no anesthesia.
There's anesthesia in all of them.
In all of them,
the
okay.
emergency situation, it's general. You're knocked out. You're not going to remember it.
Okay.
Because we don't have 15, 20 minutes to give you either an epidural or a spinal and let that take enough effect that you don't feel the surgery.
I see.
They can knock you out with general in seconds if they had to.
At any point in time, or any types of cesarean deliveries, is the mom allowed to hold her baby immediately before the medical team takes the baby?
So there's actually 3 types of C-sections. So one is elective, where the laboring person and the provider have decided together that this is a valid option for them. And there's a million reasons for that, okay? PTSD would be one of those, post-traumatic stress disorder. Then we have what we call scheduled C-sections. So they're scheduled because the baby is breech, foot or bum or feet first, transverse, lying horizontal. Maybe it's a repeat C-section, or the placenta is in a place that makes it dangerous to deliver vaginally. Okay. In an elective, and then we have the medically necessary, which is what we started off talking about. When we have an elective or a medically necessary C-section or a scheduled C-section, when we have an emergency or a scheduled C-section, it is much easier to make those requests. And it depends on the hospital and the staffing and your provider, if that is a possibility, let alone your baby status when they're born. When we're having a medically necessary C-section, we're having a medically necessary C-section because something's not progressing normally. And in those cases, it's very hard for the baby to go to the parents without going to the neonatal team first. It is, from the hospital's perspective, for safety, it's best for the baby to go straight to the neonatologist so that they can suction the baby, stimulate the baby, do those things to make sure the baby's good. For an administrative purpose, it's best for the baby to go straight to the neonatologist so that they can do everything they need to do, and then they're free to go to the next C-section or the next emergency on the floor. For the parents, it's best for the baby to come straight to them as long as the baby's stable. That requires extra staff in the operating rooms. It requires some negotiation that cannot happen typically in a medically necessary C-section.
That makes total sense.
Now, you asked me a question before about scars.
Mm-hmm.
The most common scar that we now do in the United States is called a bikini or a low incision, and it basically goes right across the very top of where your pubic hair is or within that first area. That is the most common. It is considered the safest. It is considered the best incision to go for multiple pregnancies after that, or a vaginal delivery after that. There are other incisions that are made that are done in more emergency situations. Classics incisions where they're higher, inverted incisions that look like T's, J incisions. All of those incisions are typically done in emergency situations, and because of the extensiveness of them and where they're located, ACOG does not typically recommend that you have a vaginal birth after those, because there's a greater likelihood of the scar not holding.
Mm-hmm. Are those types of incisions just easier to do, and that's why they're used for in emergent situations?
They used to only do classics, and then they figured out this low transverse, or this bikini, was safer for the moms, and it took slightly longer for the providers, and that's what they're being taught. But when you have a baby that's sideways in the abdomen, we're not necessarily going, it's going to be very complicated to get a baby out that smaller incision. It's going to take more time.
Okay.
So if your provider has to make a decision, a life decision, they're going to go for a larger incision and get the baby out faster and stabilize the laboring person faster, and worry about what does that scar mean later.
Mm-hmm. Now, when the baby comes out, how easy is it, or what kind of negotiation has to take place for mom to be able to have like the vaginal fluids to be like,
So it's no
spread
longer recommended by the hospitals or the OBs.
it's no longer recommended?
They are no longer recommending it. There is still a group of people out there that are recommending it. So the vaginal fluids,
And what's your take?
all right. So this is what we do know. The microbiome changes as you're in labor. And once you hit 6, 7, 8 centimeters, somewhere around there in labor, the microbiome that the baby's exposed to, if they were to come out vaginally, helps to colonize their GI tract. The microbiome and the organisms that are in that, if she's 3 centimeters and having a C-section, is not the same. Okay, so there are two things that colonize the GI tract for the baby. One piece is the amniotic fluid, the other piece is breast milk. So the ideal situation is for all babies to be breastfed so we can colonize their GI tract, and it's the best food for them whenever possible. And babies that are born by C-section and breastfed do really well overall.
Mm-hmm.
If we had to have a C-section, the ideal kind of scenario is for the laboring person to have been in labor for some period of time. So the baby has gotten a bunch of contractions to stimulate the pulmonary system being the lungs and the central nervous system. So they're ready to breathe, they're ready to be out on their own. And that you have gotten into active labor. So the baby has been exposed by some of that colonization, hopefully, and then for you to breastfeed. And those babies do great, right?
Mm-hmm.
The concerns around the microbiome are, what if your baby doesn't get all that colonization? And wouldn't it be best to get both kinds? And that's true. It gets complicated because that correct cocktail doesn't exist until active labor transition. So that makes it confusing. And then the second thing that makes it confusing is if there is group B strep that was not caught on our normal testing, or if there's any other type of infection going on. I mean, herpes is one of the ones that we talk about, BV, the baby would be exposed to that at the same time they're being exposed to that microbiome. So what's better?
Mm-hmm.
What are the chances though? I mean, if they've gone through all that testing prior to delivery, what are the chances that like they're even going to have any of those infections if they've already been tested prior to the delivery?
Most of them, none. So group beta strep is the only one that's kind of tricky. And group beta strep is tricky because we test you around 36, 37 weeks. And it is a bacteria that acts like a virus. So it has active periods and has dormant periods. So if it was dormant when we tested you and we believe you're negative, and then you're active 4 weeks later when you're having your baby, we're not treating you for it because we're treating you based on your 37-week test results. Now, the American, the medical system tried to come up with like a litmus test so we could test individuals in labor and decide who to treat and who not to treat. That test didn't work out. It had a really high false positive rate, so they stopped using it.
Mm-hmm.
So again, low, Jordan,
Mm-hmm.
the question becomes, what if you're that one person?
Mm-hmm.
And from the medical establishment's point of view, that one person is not sufficient. Like that's too big of a margin of error.
Okay. What about if you decide to do a hospital birth, are you able to forego vaccinations for your baby, or is it always required?
Each state is different.
Okay.
Again, it's America, so you can decline anything you want. You do have to understand two things if you decline. One, neonatology will probably come into the room and they will have a discussion with you about what you're declining, why you're declining it, and why you should be doing it.
Mm-hmm.
And the conversation can be kind of aggressive and a little threatening, sometimes depending on who's doing it. And the other thing is the hospital may make you sign a piece of paper called an AMA, or against medical advice.
Mm-hmm.
And I don't know this for true, but I have heard about somebody who baby had developed something that could have been treated in the hospital that they had declined. And when the insurance company found out they had signed the AMA, they decided not to cover treatment.
Mm-hmm.
Now, is that true? I don't know if that story is true. That's a second, third,
Yeah.
fourth hand story. I don't know.
Okay.
Wow. I think this conversation we could talk about it for the rest of the time. So let's save more on microbiome from mom to baby for another conversation.
Yeah.
So let's talk now, shift gears a little bit and talk about more of the recovery side, starting with when they start to sew everything up.
Yep.
Are you in the room during that process, Ursula, whenever you are a person's doula? And what does that look like? What's who's doing it? How long does it take? And then what is the delivering mother have to do until they can get up and move?
Fantastic. So Jocelyn, I do have a blog about this that goes through the steps by steps of the C-section. So I'm going to send that to you so you can tack it onto the notes for the reader, for the listener, so they can
Perfect.
see the whole thing, because we're kind of bouncing around. So in the operating room, there's usually two physicians. You're the physician that's been with you with labor, and either a hospitalist or another physician on the room, because there's we always have 2 physicians in the room. Then we have the NICU team, which is usually 2 people. And then we have anesthesiologists, and we have at least 2 other nurses, 1 for you, 1 for baby. And all the documentation and the techs. Like, it's a busy place. Depending on what's going on the floor, once the uterus is stitched, 1 doctor will take over, typically at that point, completing the repair. Once the uterus is stitched, then they put the abdominal muscles back in place, and then they start to layer the skin, and they sew the skin together, and then they apply like a pressure bandage over it. Then they clean you up. They start to disconnect you from things if you're stable, and the team helps to move you from the operating bed to your recovery bed. Then they typically give you your baby to either hold in your arms, or the baby, if you have the shakes, they put the baby between your legs. So the baby's still getting contact warmth, and we're not worried about you potentially, dropping the baby, but the dyad is back together. They take you into your recovery bay. Now, whether your doula is with you or not, depends on the facility, depends on the providers, and it depends on the situation. If it's an emergency situation, no. If it is a controlled situation, there's a possibility, but there's multiple people who get a say: the anesthesiologist, the doctor, and the charge nurse. If one of them says no, it doesn't happen. You're allowed 1 support person. So if your partner doesn't feel safe in that environment, obviously the partner and the doula could swap out. If we always encourage the partner to go whenever possible, because we want them to see their baby being born, right?
Mm-hmm.
You come back to the recovery bay, usually that's where your doula is at. And the nurses will be switching over all your electrodes and doing all that kind of thing. And then as soon as that's done, the doula nurse combination will help to unsnap your gown and bring your baby to your chest or to your breast or your chest, depending on what's going on, and help to facilitate breastfeeding while the nurse is doing all their documentation. They're doing all the medications that need to be given. They're checking for bleeding. They're doing abdominal, what we call fundal massages. They're doing the baby checks. There's a bunch of protocols that have to happen during that time period. It is not uncommon for the person who just delivered to have body shakes. So having an extra set of hands to help support the baby while the baby's on their chest or at their breast can be really powerful. Oftentimes the partners are kind of sitting on the chair going, wow, that was a lot. So giving them some orange juice, giving them some sugar, giving them something to eat, checking it on them. And you're typically in that recovery bay for about 90 minutes, 2 hours, depending. And then once you're stable, they move you to your postpartum room. While you're there, you're numb. You're either had general anesthesia, you had an epidural, you had a spinal, so the most you're going to get is eventually you're going to be able to move your toes. They're going to say, can you rotate your ankles? They just want to make sure that the anesthesia is wearing off appropriately before they move you. There's not a whole lot that is done for recovery at that point. Most of it is pain management and dealing with the shifts in the body and the hormones from being pregnant to not being pregnant. Right?
Mm-hmm.
And that's really what the nurses are focusing on, is medical management, pain management, and, assessing your situation and then assessing the baby situation.
What's something, when you say medication management, pain management, what are you referring to?
Yeah. So in some hospitals, they have something called PCA, or patient controlled anesthesia,
Mm-hmm.
where you can get, like, you have a little push button and it's timed, and you can give yourself a little bit of medication through the epidural space. Using that, for some people, it is, it's IV Tylenol, it's muscle relaxants, it's anti-nausea medicine. It can be for breakthrough pain. I think I said muscle spasms already. It's a mix of medications, and it varies by individual. So if you are planning a C-section and you do know that your body doesn't tolerate certain medications, that is definitely a conversation you want to have with your providers ahead of time, so that we can make sure that we have medications that you respond well to for recovery.
That makes sense. And then at what point can someone start moving? Like what is a typical timeline? I know everyone's different with when anesthesia wears off, but in general, how long does that take? And then what are moms allowed to start doing? I know what I request my patients to start doing once they get cleared, but what's that process, that clearance process in the hospital?
So it varies by person, and it varies by the medication they were giving. So if they had general, they're not going to be able to get up on their feet until, if they've passed gas, they've had some substance in their body, and that's going to take a little bit more time. Some hospitals, if you had an epidural, they actually leave the epidural running for 12 to 14 hours after the C-section for pain management. And they really don't want you doing a whole lot until they take that out and you start getting sensation back. Other people request to have the epidural removed right after they come out of the operating room, and they prefer to deal with oral pain medication at that point. And the individuals who have had a spinal epidural, which is one of my favorites because it wears off quickly, you have to use oral medication, which then encourages you to get up and move around more faster. Okay. The first things I'll say to a client are, first and foremost, as soon as your body can, start drinking, and drink frequently. Staying hydrated helps to move the GI tract. Warm liquids are the most beneficial. Avoid carbonated drinks because they increase the gas, but drink. And that helps to flush the anesthesia. It helps to fill your bladder, so it makes you get up and go to the bathroom as soon as you can and get that catheter out. But it speeds up the process. Interestingly enough, if you're somebody who has a hard time like drinking large quantities, there's really good studies that show that if you chew gum for 30 minutes every 2 hours, that also will increase your bowel movement, and patients will feel better. And because the anesthesia will move, their bowels will move, they can eat faster. So chewing gum is another great option. Movement specific. Right after the C-section, they usually have you laying flat. And then once you move up to your postpartum room, most people start to bring their beds up to at least a 45 or a 90-degree angle. And they have a tendency to get stuck there. They never take their bed flat again. And so I think that's the first piece, is making sure that the back of the bed is being used, that you're staying with your back at all different levels. And I need to make sure that you're spending part of the day flat. Yes, it may feel like there's pulling and tugging in your abdomen, but it's really important for your back. It's important for your butt. It's important for your abdominals to lay back flat. No matter if you're flat or upright, you can start with small body movements. Bend your ankles, bend your knees, switch from side to side, put a pillow under one hip so you're not always flat, and then move it to the other side. And those things will also help to move the gas. It'll help to move the bowels. It'll get everything back in place again. And then as soon as we can get you out of the bed to go to the bathroom, my favorite things is to hold on to the railing and slowly like march and step or do high knees and get them a little bit higher each time.
Okay.
Or when you can walk to the bathroom, stand next to the bed, march, slowly walk to the bathroom, support your incision as you go down, support your incision as you come up, but then, marching as you come back to the bed. A lot of people have a tendency to shuffle their feet like an old man, and that doesn't help anything. So those nice big high knees. And a trick for that is to always, if your pain medication's wearing off, take your pain medication and then do the high knees once your pain medication has kicked in, so that you're not all up in your head about if what you're feeling is safe or not safe. You have that little bit of pain medication on. Use pain medication as you need it, especially for those first 3 days. It's really appropriate. And some people do really well with heat. So not heat to the incision, but heat to your back. If you're having gas pains, sometimes they radiate up into your shoulder. So putting the heat on your shoulder, putting the heat on your upper back, you're now holding a baby on the outside instead of on the inside. So now
Mhm.
your shoulders and your arms are going to be taking a different burden as well. So that's what I would say, like the first day, like those are your goals. Drink, small body movements, and as soon as you can, get out of the bed and do those bigger body movements and high knees and don't shuffle.
High knees and don't shuffle. That's a great tip. I have my patients do heel slides as quickly as they can, but I uh did not even think about the high knees with walking and the shuffling. What about when they remove the catheter, or what's im what I think it is, they have to empty their bladder, they test their bladder, and that's a criteria for discharge. Am I
It is a criteria for discharge. So, and in rare cases, we can send individuals home with a Foley catheter in place. That's not ideal. We really want you emptying your bladder on your own. So typically, that happens 14, 24 on the outside 36 hours after delivery. Really, if there was complications or depending on how much pain medication you used. Um, Once your bladder, you're voiding, you're going to the bathroom on your own. We're going to call that days 2 and 3 because you're typically in the hospital days 2 and 3. I would encourage you to start in addition to everything we talked about. So still continuing with your bending your knees and your ankle mobility and shifting your body and the high knees, walking the hallways. And I also would love for you, after you do your high knees, standing next to the bed, holding onto the bed, and actually doing side bends and opening up the obliques on both sides as well, because we forget about those.
Mhm.
That's usually like if we can get you walking 2, 3 times a day, you're getting up to go to the bathroom every couple of hours, you're marching for the bathroom, and you're doing side bends, and you're lying flat periodically, like, that's a sweet spot for most people. When you're getting discharged, make sure that you have your pain medication on board because even though you might feel great, the act of getting into a car, driving home, getting into your house can be kind of overwhelming and it can take a lot out of you. And going straight to the main level couch, not going straight upstairs and doing extra stairs can be helpful. Um, and then as far as stairs, what I say to my clients is body weight alone, don't carry your baby on the stairs for at least a week. And the first day home, I want you to do 1 flight up and down, the second day, 2 flights, the third day, 3 flights, and then you just keep doing stairs because nobody wants to do stairs. And that part of that's because we don't do the high knees and it's hard. And part of it is just mobility and moving around.
Do you find like what do women typically, if they have complaints about urinating and bowel movements right after having a baby?
Yeah, so there's a fantastic trick for urinating. So I think we probably know some of these. So for example, if you have a hard time peeing, you sit on the toilet and you run the water, the running water sound can be very helpful. We also find that Americans have very poor posture in general. So we have a tendency to sort of lean forward on the toilet. So if we can actually go upright or even lean backwards and rest on the back of the toilet can be very helpful for emptying the bladder. If it's really difficult, an old midwife doula trick is to put a couple of drops of peppermint oil into the toilet water and sit on top of it, and the fumes can help to get you to empty your bladder.
Interesting.
Oh.
Um, with both urinating and with poop, right after delivery, you're going to have a squeeze bottle called a peri bottle. And what we tell you to do is fill that full of warm water. And when you're done urinating or having about, well, first off, as you're getting ready to urinate, you squirt some of that onto the urethra and the labia so that if there's any micro tears, if you've had a vaginal delivery, you may have micro tears, that when the uric acid in the urine hits them, they can
Mhm.
sting. So it helps to dilute the uric acid. But when you're done urinating or you're done having the bowel movement, use that spray bottle to wash yourself, kind of like a bidet.
Mhm.
Okay.
And you take your toilet paper and you blot yourself.
Mhm.
As far as pooping, it's not uncommon for women to take or individuals after surgery to take 24 hours, even 48 hours to have a bowel movement because you haven't eaten for 8 or more hours before surgery. You haven't eaten for probably some number of hours after. Your body has to take time to get going again, and you've been without food for a period of time. So most providers will recommend a stool softener, Miralax, Colase, Senecot, something like that. Those are the ones that we typically recommend for labor and delivery to help. And I like to say a minimum of 2 weeks. So that would be something that everyone should have on hand preemptively for recovery.
Would you suggest, or do you suggest a support or a bind, to bind the belly postpartum, or
So,
even like with coughing, a pillow?
so with a C-section, we don't recommend anything initially. However, the pillow is my all-time favorite tech. So you simply take that pillow, hold it to your abdomen whenever you have to stand or whenever you have to sit, or if you have to cough or sneeze. It just makes a huge difference in that feeling. A binder that is for your hips would probably be fine, but not a binder for your abdomen during that initial recovery period. We don't want to push things further down. We want everything to settle back up where it needs to be. But if your hips are unstable, I have them work with a specialist like yourselves or somebody else to pick the right binder, because binders with a C-section too early can cause other problems.
That makes sense. So week 1, we have the very first day, pushing the water, doing as soon as you can, movement of the toes, the ankles, the knees, high knees versus shuffling, moving in bed, changing position. That second and third day, going to the bathroom, getting up and going to the bathroom as soon as you are able to. Again, walking the hallway. We talked about side bend stretching. And then once you get home, the first day at home, stairs, 1 flight of stairs up and down. Second day, twice. Third day, 3 times.
And avoid taking baby up the stairs for a week just to get comfortable with the
And
stairs.
it could be a lot longer than that, depending on the
Yeah.
individual. Like you're only walking yourself up. You're not even carrying, like maybe
Nothing.
you're carrying a water bottle as you have the other hand on the railing. That's the extent of it. And then walking around the house.
Okay. First 2 weeks, stool softeners.
Yep.
We talked about
You're gonna have
No carbonation.
the
No carbonation, using the peri bottle for cleaning up as needed.
no binder around the belly. For how long?
So after 2 weeks, so your provider will see you at 2 weeks and they'll see you at 6 weeks. And once they say that your scar is healing well, then you can pick up your activity a little bit. You can start doing like floor yoga. You can start seeing your modality specialist if you need to see your pelvic floor person, if you need to see your chiropractor, and they will work with you on their comfort level and your healing. And again, that's different for everybody. I've had women who can't walk need to see the chiropractor on their way home from the hospital just to help with their hip sockets so they could walk again. That's an exception. But most providers, unless it's an extreme situation, they don't want to see you for at least 2 weeks. And you talk to your providers about what their comfort level is and what your needs are.
Any other recovery tips?
Yes. So, scars can be ugly, and I'm really not so much concerned about an ugly scar. What I'm really concerned about is how does your body move? So sometimes when the skin knits, it causes adhesions. So underneath the skin, on top of the muscle, is the spider web material out there, and the fascia. And when we cut the fascia, this fascia works. So if you've ever gone outside at night and you broke a spider web, and then the next morning the spider web has come out and they've remade their web, but the web doesn't look the same. There's like some tighter areas and some looser areas. When we cut your skin, your fascia does the exact same thing. So there are things that we can do after there's the early things we can do are the modality. So laying flat, sitting up, moving our bodies, the side bends, the high knees. Then we can start working, there's massage techniques, which I can send your listeners if you'd like. We can use TENS units to help to relax the muscles and have the fascia knit normally and not attach to organs and do weird things. You can do cold laser, you can do ultrasound, and those things will help to heal the fascia. And once the fascia is flat, the scar will be flat. So I think if we don't think about the looks of the scar, we think about the functionality of the scar
Mhm.
itself will get fixed in the end.
Mm-hmm.
The other thing I will say is that if you are an individual who gets keloids, your scars get these horrible lumps on them, then some providers can actually inject the incision with a steroid in the operating room as they're closing you up or after they've closed you up. And the steroid can help to prevent adhesions. So if you have adhesions yourself, a history of adhesions, family adhesions, that's something to discuss with your provider. That could make a difference in your recovery and your healing.
Something interesting with the keloids is doing the functional medicine work with different patients who they, have had anytime they get a scar, they know they're going to keloid. Like it just like, oh, I think it's genetic. What was interesting though is when we got their immune system healthier, getting their gut healthier, a lot of their keloids flattened out. And so just know that there can be hope, even if you feel like you have these ugly keloids, you keep working on your health, just moving forward, that the body's pretty amazing and how it can adapt and change.
It is totally. And I probably, for fairness, if we're talking about keloids, which is an extra bundling of scar, we also have scars that separate or dissidence. So if you're somebody who has poor collagen in your body or has a history of scars separating, which is what my personal history is, then there are different ways of suturing the skin. So you can talk to your provider about that ahead of time. But again, going into into your C-section with a healthy microbiome, taking your probiotics, doing the things you need to do, but also coming out, eating your live probiotics, taking probiotic supplements to make up for the antibiotics that your system received for health reasons, reestablishing your gut health.
Yeah.
Huge, huge places that we don't immediately think about.
Yeah.
And that microbiome within your body for you actually transfers to your baby through the breast milk as well. But you're doing
Absolutely.
it not just for yourself, you're doing it for your baby, and you're doing it for your baby's long-term health, not just the current time period.
Are these conversations that the people in the hospital are having with their patients? So
No.
how would they know? I know we certainly have these conversations, and but who else is having them?
So hopefully, if you have a really good childbirth educator, this is a conversation you could be had with a childbirth educator, or it could come up in the classroom. This would be something that, again, that your doula should be able to help you with, especially if they're an experienced doula. They would have this knowledge and information. Um, I think you have to look at alternative healthcare providers. The hospitals don't stock probiotics. They're not available in the hospital system. So, yeah, right. I see your face,
Are
Jocelyn.
they afraid that the probiotics are going to get out free and then
I, I have no
well,
idea.
the probiotics don't make the money.
Probiotics don't make the money, but probiotics are not made by Pfizer or by a big major company, and they're not regulated the same way. And because of that, I think that's why they're not stocked. But something as simple as asking, they have stool softeners, but they don't have probiotics.
Yeah.
So knowing that, having a conversation with your provider of, can I bring them in? What's the process of taking them if I bring my own in? Bringing some of your own food in that might have good stuff, or sending your partner out to go to Whole Foods and get you a bottle of kefir that you can then put in the fridge and label for yourself, and you can have a little bit every day as you're recovering. Small things can have huge impacts.
And I definitely recommend before you have the baby, I'd be taking these things, but wouldn't necessarily switch it up to always something new right after, just because you don't always know, right? And I know, trying to avoid gas and things like that, especially if you've been through a C-section. So yeah, I would probably recommend trying these things out before you take them right after.
Agreed.
Speaking of what you said with gas, these direct quotes of people that I've treated, they've been like, they didn't tell me about this.
Yeah.
Like, No one talks about this. So a couple of pain points that people have shared that with was gas pains
Mhm.
and then troubles with the catheter, or if they can't empty their bladder, that I've had complaints about the catheter process. If you don't mind talking a little bit about that, if you can, and then any other pains or unexpected things that come up or that are just part of having a C-section that just you wouldn't expect
So
for.
gas is probably first and foremost. So avoiding carbonated drinks. As soon as you can, getting rid of the straw, because we drink more, 20% more with a straw, but when we get to the bottom, we start going like that, we're taking in a tremendous amount of air into our system. If you're good at burping, burp. Like every time you drink something, burp, let that air out, let it go. Chewing gum, like we talked about,
Mm-hmm.
30 minutes every couple of hours helps you to pass the gas. And then in the hospital, I think we typically give you Gas X if you're having extreme gas pain. And I would just ask for it preemptively. Like once gas starts building, it escalates very, very quickly. And Gas X could be one of those things that you also have at home along with those probiotics, right?
Mm-hmm.
Just have them on standby with the stool softeners as well. And I think, like Jordan said, knowing which ones, knowing which probiotics your body likes, knowing which soil softeners your body likes, so that you're now not hitting a body that's gone through a surgery who's now trying to heal with a new product
Mm-hmm.
can help to diminish. So those are my big ones for gas, right? And move.
Mm-hmm. Mm-hmm.
I know it's counterintuitive, but if you don't move, your bowels don't move. And if your
Mm-hmm.
bowels don't move, your gas doesn't move. And it's just a
Yeah.
snowball falling down a
And movement
hill.
is important for recovery of the abdominal wall, everything.
Movement is medicine, and
Mhm.
we don't give it enough credit.
Yeah.
Start small, right?
Now, you CrossFitters out there, do not just go to your CrossFit gym. We're not talking about that kind of movement. And I have to say that.
Something me and Jocelyn are doing right now too is we're finishing up writing a postpartum guide, and including in that you're doing a lot on like the movement side, and I've been getting just really deep into research for like postpartum healing with nutrition. A great resource that has been for me for just more learning. Have you seen this book, Functional Maternity?
No, I have not.
It's written by a doula. I think she might also be a nurse, but Sarah Thompson. And I mean, she gets, I think anyone could read it, but she really does really like go into the chemical pathways and the science too of like why like choline and like why folate over folic acid actually based on research. And so great resource for me so far, but wasn't sure if you had read that.
No, I appreciate that. And I'll add, like folic acid's a huge one for me. Another one that I really like to talk about is B vitamins,
Mm-hmm.
because some of these medications and some of these pain techniques that we have, such as nitrous oxide, for if you're at a facility that uses that, they actually deplete your B vitamins.
Mm-hmm.
If we deplete your B vitamins postpartum, that increases your likelihood of having postpartum anxiety, postpartum depression, and sleep disturbances,
Mm-hmm.
which cascades in a different way.
Yeah.
All good stuff. Well, I'll make sure that the book, your blog, our guide is all linked into the show notes. And then I mentioned the pain associated with the catheter. I
Yes.
never did not hear about pre-spraying with the peri
The
what's it
Perry
called?
bottle.
The peri bottle. And
And if somebody's like really sensitive there, they can use a lidocaine gel, and they can apply the lidocaine gel before they remove the catheter or they reassert the catheter.
mhm,
So those are easy requests. The hospitals typically have them on hand, that you just might have to wait for them to find it in the Pyxis system. Um, the peppermint oil on the toilet
oh
under
right.
the toilet water, those fumes really do help. Running the water, hearing the sound of water is
Mhm,
very powerful. Meditation, breathing, being present, like I said, not leaning forward to pee,
mhm,
making sure you're straight up, or even for some people, slightly reclining,
mhm,
especially with everything being so pendulous after giving birth, everything's falling forward. So holding your belly, holding the uterus, pulling everything closer to your spine could help to tuck the uterus enough and the bladder enough for you to pee functionally. Those are the top ones. The urination, there's not a whole lot of great tricks there, but those are the best ones I got.
I think just knowing these little tips are super powerful. And if we give too much, I think it's overwhelming. So even if you've had a C-section, I think it's a good idea to spray yourself with a peri bottle. Because think about it, you're a good period of time you have a catheter.
You have a catheter, and chances are I mean, especially if you had a medically necessary C-section, you were having vaginal exams.
Yeah.
Had gloved hands up in there feeling around. There still could be micro tears to your tissue that is going to affect your healing process.
Absolutely, for sure. And then not being afraid of movement, but not being overzealous during for movement as well. It's just in order for recovery, you do need to move to a certain point, but that doesn't mean that you're walking a mile in that first week. It's the short walks to the bathroom, around the house. And then after that initial week, just really taking inventory of how much movement you're getting and gradually increasing it versus like, I hear people, this is just an exaggerated example, and it doesn't necessarily have to relate to my patients who have had C-sections, but they haven't run in years or a year. And then the first time they run 30 minutes or 3 miles.
Right.
And this is after a large change in their body. And I'm just like, oh, even though if they didn't have any problems during that run, like our body's super resilient, and you may not feel the impact of 3 miles if it's been a year. But same thing with, walking, going on a hike in Camelback, your first
Yes.
8 weeks, that's a bit much. Let's
So
start
the docs will say at 6 weeks, you're good to go, you're off restrictions. We know that scar may have knitted, but it's not at full strength until I think 6 months after delivery.
Yeah.
So, yeah, you're cleared to start exercising, but that doesn't mean you can hit the gym hard. It doesn't mean you can go immediately back to hard stuff. That's where we have problems. Give your body a chance, heal, figure out your baby, figure out breastfeeding, figure out how to be a parent, work in small times, structured, focused, pelvic floor work, abdominal work. We haven't even talked about the abdominal work, but abdominal work, alignment, get your stretching in, and slowly build up your exercise. And you'll be surprised at how fast your body will come back when you do it that way versus if you go full force early and then you actually have a secondary issue or an injury we're dealing with.
I think a lot of people don't know that overdoing it, what the impact, it's like any surgery. In the first year, that area is like common. It's common for inflammation to
Naturally keep
naturally
going
just
there
go
when you're in an
there.
inflamed state.
Yeah.
And with inflammation comes fascial restrictions, which can then lead to adherence to the pelvic organs. And it's not a process that you necessarily notice right off the bat. It's a slow build. And like Ursula said, it takes time for that scar to mature and handle those forces. So it's a good idea to really move with control and slowly ease back into it in those first 6 months. You have a lifetime to move your body in an intense way, gradually get back into that.
Yep.
So in today's episode, we talked about types of C-sections. What are key recovery tips when it comes to movement, when it comes to nutritional considerations, as it relates to diet, fluid intake, recovery tips? There's a lot that we all could talk about, and we'll just push that into our next conversation in the coming year. But as we conclude the episode, what would be your top advice as and if it's the same as last episode, that's fine, but what tip would you give to people in terms of their pelvic health, like in their overall health, what they should start doing now?
So my recommendation always is to get assessed early and get assessed often. And it is easier to assess a pregnant body earlier in the pregnancy and address issues than waiting until you've been told that there's an issue or a concern or a problem and then having to try to address it with a larger baby inside. And I also think establishing care with a team and developing trust with them when you're pregnant or prior to your pregnancy or on even your fertility journey, because chiropractic, pelvic floor, PT, acupuncture, they all have a place in fertility as well. So starting early, starting often, and then if there is an issue, obviously seeing your providers after the fact, but I do believe that every single individual should be seen at least once or twice just to make sure everything's everything's in place. There's no structural weaknesses or too much tension in other areas, which is the part we forget. We always think about weakness. We don't think about too much strength. Will make for a better pregnancy, a better birth. It'll make for a better recovery, and it'll actually stack the deck for the future, whether that's another pregnancy down the road, whether that's perimenopause and menopause, like whatever that looks like for everybody. But start early, get assessed. When the baby is small or you're not yet pregnant, do your care as needed, and then obviously follow up with your care providers afterwards to make sure that everything is back where it needs to be in a way that it should be to prevent injuries and to facilitate a great recovery, short-term and long-term.
Boom. Well stated. It's nice for someone else to say that instead of me.
It's true. I can, so this is your domain, right? Not my domain, but I can tell you that my clients who have done the work, fertility or not, in pregnancy, and then get checked out afterwards and have treatment if they need treatment or don't, they have much better recoveries. They have much better relationships. They feel more body positive. They have a better relationship with their partner. They have a better relationship with their kid, and they have better futures. I see it over and over and over again. And yes, there's an exception to every rule. I had one client email me after I posted about our last episode, and she goes, Ursula, I did everything and my daughter still got stuck. And I texted her back and I said, yeah, but we tried for 9 hours to push your baby out and we couldn't move your baby even after 9 hours of hard work. Like, she wasn't coming. Do we know why? No, but she picked her exit. You did your work. You did the body work. You did the labor work. And then you had to listen to your daughter. And she said, yeah, I need to come out by a C-section. I can't fit the other way.
I got the chills on that.
Well,
You do your work, the baby does their work.
Yeah, and I think too, because like you said, we don't always know. And I think for us to always assume that we know everything, or we did all this stuff to prepare, so we automatically have to have this outcome.
Yeah.
I think sometimes there's more powers that be that know better for what is needed at a time, and yeah.
Well stated. Well stated. But so before we sign off for the day, Dare to Birth and Ursula, they have a great promotion for our listeners, $100 off doula care or postpartum services in 2024. So if you are an expecting mother, be sure to check out what Ursula has in store on it's daretobirth.com.
BirthYouDesire.com. You're thinking of Alex. So just do that.
Let me read.
Just do that again.
I have to. Okay. Yeah.
Alex is Dare to Birth. I'm Birth You Desire.
That's right. That's right.
It's okay. Cut.
So Ursula and Birth You Desire, they have a great promotion for our listeners. It is $100 off doula services or postpartum doula services for the year of 2024. So make sure you check out what they have in their services. www.birthyouDesire.com, or you could reach out to Ursula. Her information is going to be in the show notes. So if you have any questions, reach out directly to her.
And if this information was helpful for you, please like and subscribe if you guys would like more of this kind of content.
And Ursula, thank you so much for coming on the show again. Your insight is just so valuable to our listeners, and we are so excited to have you on the show in the future.
Thank you. I hope everyone has a great day.
Thanks.
Thank you. Until next time with Real Talk with the VagihnaDocs.